Hi, Dr. John Torres here on my Doc to Doc series, where I talk to doctors, experts around the world about all things pandemic, all things coronavirus, and hopefully things that information you can use to help you, your family, your loved ones, and your community get through this pandemic sooner rather than later and as healthy as possible. To help me do that, I bring in experts, and those experts give us the information we need to know. And today we're lucky to have with us Dr. Buddy Creech. He's a friend of the show, as we say, and he is actually the Associate Professor of Pediatrics, the Division of Pediatric Infectious Diseases at Vanderbilt University School of Medicine, that's in Nashville. And he serves as a director of the Vanderbilt Vaccine Research Program and principal investigator on some studies here. And Buddy, thank you for being here with us.
John, thanks for having me. I love being able to take part in this, and hopefully I can help in some way.
Oh, you bet. And for full disclosure, you're an investigator working with the Moderna vaccine.
I am. There have been many of us who work in vaccines who've been called into action right now, primarily through the National Institutes of Health. So that's where the money comes from to conduct these trials. But I'm leading the Moderna phase 3 trials at Vanderbilt, the Johnson & Johnson phase 3 trials. And then I'm one of the co-principal investigators with Dr. Evan Anderson at Emory and Dr. Berthold at Meharry Medical College for the Kid Cove Moderna pediatric study.
Sounds like you just kind of sit around and binge watch a lot of Netflix. So not much going on in your life. Let's talk about the news here. And the news is the Pfizer vaccine and the VRBPAC that met this week. And they basically gave thumbs up for recommending the emergency use authorization for 5 to 11-year-olds to get that vaccine. Tell us about that.
Well, I love that VRBPAC is now becoming a household acronym because it before was just sort of nerds are us. It's a bunch of vaccine scientists and epidemiologists talking about the issue of risks and benefits of a vaccine or similar product. And I think for those who may have tuned in or have seen the excerpts from it, there was a lot of discussion about what it means to have a safe and effective vaccine for these school-aged children. I think most of us as parents want our kids in school. We don't want to have to bring them home for quarantine every other week and get constant nasal testing for COVID. And so having a preventive strategy for this age group is really important. And we want to do that in a safe way, of course. We want to do that in an effective way. But I think at this point in the pandemic, we're finally at that point where we say we may have underestimated the overall burden of this infection in children. We know it's milder. We know they navigate it better than certainly older adults, but we also recognize that there's a burden of infection in children, and now we've got a tool to prevent it.
Keeping on that subject, is that mixed messaging muddling things up a little bit? Because even I was saying early in the pandemic, which frequently every expert said, children don't get it as much, they don't get sick as much, and they don't die as much from it. But the caveat would be they do get sick, they do catch it, and they do die from it. Did that muddle the picture?
Well, I think this whole picture has been muddled because we've been trying to draw it while it happens. And that makes it challenging for us as epidemiologists. We don't have the luxury of sitting and waiting to see the story evolve and then making decisions about how do we move forward. And that's why we launched these pediatric studies, even at a time when children weren't being as readily infected. Now, we can look back at those times and realize that there was a significant number of children who were getting infected, but not having symptoms, right? And this helps us explain why in a family, the parents might get infected, the child have no symptoms whatsoever, and it would be reasonable for us to say that they never got infected. But when the CDC now has done these seroprevalent studies, so how prevalent are the antibodies to COVID in just leftover blood specimens, in some areas of our country, upwards of 50% of children have evidence of immunity, at least mild immunity, to this particular virus. But then the important thing happened in the late summer, and that was Delta. Delta changed everything for us. For the first time in the pandemic, our children's hospitals began to see a significant uptick in the number and the severity of infections, including teenagers with risk factors that are similar to older adults, like diabetes or obesity. So I don't think that we were wrong at the beginning. I think both are true. This pandemic has been less burdensome to children. That changed a bit during Delta, and we need to be prepared for what comes next.
Like you mentioned, VRBPAC, nobody really heard about that 2 years ago. Now it's going to come out in a dictionary somewhere as a new word that's out there. But it's interesting. What I tell people all the time, if you listen to the VRPAC meetings, if you're a science nerd like I am, it's great to listen to. It's fascinating to hear the scientists debate at that level. But if you're not, it's going to be pretty boring. And the result is what's important at the end of the day. But this one was particularly interesting because in the middle of it, what they said was that this was a tougher decision than they thought it would be, because the big debate point is, do kids really need vaccine? What's your feeling on that?
Well, I think some of the members really articulated it well, and certainly Dr. Amanda Cohn from the CDC articulated it probably as best as anyone, of saying we've had more children die of COVID since the pandemic began than the last several years of influenza, and yet we have prioritized influenza as something we wish to vaccinate against. That's a compelling argument. The second would be that we don't always know the long-term consequences of COVID. We talk a little bit about the fear of the unknown as it relates to maybe the long-term side effects of a vaccine, but we already know the long-term effects of COVID. We see patients with long COVID. We see patients who develop heart inflammation, or they develop blood clots during their illness with COVID. So we already know that there are some significant side effects from it.
Including children.
Exactly, including children, particularly our older children. And I think that's where, as we get lower in age, VRPAC will continue to wrestle with this, to approve or not approve. And then the CDC's Board of Advisors, the ACIP, they will now have to take that approval or authorization from the FDA and then actually operationalize it. And what you saw, I think the VRPAC advisors saying was, we don't yet know if we've reached a point where we want this to be mandated, let's say, for school entrance, or mandated for every child. Maybe we need to be prioritizing this for high-risk children with heart disease that they're born with, or those who are technology dependent, like who have breathing tubes or have to have ventilators at home, those types of children that have underlying medical conditions. And I think that's where the meeting next week of the CDC advisors will be really telling, which is to say, do we need to prioritize some kids over others as we think about who needs to get vaccinated? So I think the story is still unfolding, but I think the important piece is that for those parents, particularly those of children with underlying chronic medical conditions, there's now going to be an option for prevention that we didn't have just a few days ago.
It's interesting you bring that up, because one of the very big discussion points was that, yes, children do need the vaccine, but the question was, do all children need the vaccine? And what they came down to is what you're talking about, is saying, we need to give them the option of getting this vaccine and move it forward to the ACIP and the CDC to decide, using what we've talked about and what the other science is out there. Are they going to say only certain groups, like we had initially with our vaccine as adults? Remember, initially it was just high risk groups and the elderly, and then it's filtered down to the rest of the population. But one of the things the VRPAC members said is that they didn't want to tie the hands of the people making those decisions. They wanted to give them the option. Plus, I think more importantly, they wanted to give parents the option of getting to the point where parents could say, let me get more information and I'll decide as a parent whether my child gets the vaccine.
I think that's exactly right. And I think for those families who have a member who's immunocompromised, this is an easy decision. For those families who have someone with a chronic medical condition, easy decision. For a family who maybe all of them have had COVID recently, maybe all are vaccinated, there are going to have to be some conversations with the pediatrician to say, how do we go about vaccinating? There are going to be some parents who ask the question, well, my 7-year-old has had COVID. Do they need to be vaccinated? I think the answer from the data that we have in adults is absolutely, because not every infection is created equally, and many of those are not going to be protective for very long. But there may be some nuance that we can build in after careful conversation with pediatricians. I think the other important thing that VRPAC wanted to avoid, and I think ACIP will want to avoid, is anything that creates health disparity. And what I mean by that is, if we limit vaccine availability too much, we begin to only offer vaccine for those who are medically very knowledgeable, or who might have some giftedness in navigating what's quite frankly a complicated healthcare system, rather than making it available to everyone who needs it.
And one of the big things they were wrestling with too is the very real consequences of COVID, which you mentioned. And the AAP, the American Academy of Pediatrics, said that, they come up with the reports that are usually a week delayed. And they said in the last report, almost 118,000 children over that week period had gotten COVID. That was 25.1% of the COVID cases were because of children. So, and it's real. And we know in this age group, around 100 children have unfortunately died from it during the pandemic. So those are the real effects of COVID. And they're weighing that against the potential theoretical risk of myocarditis in this age group, because in the study, they didn't see any myocarditis, but that doesn't mean it's not there. But if it is, we've seen in other, particularly young males, it's a very, very rare risk, correct?
I think so. When we look at myocarditis overall, it's really the first year of life. It then plummets during preschool years and early childhood. And then it's not until adolescence that the rates of myocarditis start to peak. And then once you get into early adulthood, again, it starts to go down a little bit. I think this is why we didn't see it in the initial rollout, because that was mostly older individuals being vaccinated. We saw it as we expanded into young adults and teenagers. And my prediction, having looked at this quite a bit for myocarditis and leading the pediatric studies, is that there's such an influence of the sex hormones during adolescence that these 5 to 11-year-olds are not going to have the same likelihood of myocarditis as we've seen in young teenager and young adult males. We're watching this story very carefully. We're leading efforts to understand it and to be able to provide guidance for individuals who may have experienced myocarditis. But I think I need to put a point on this. When we look at, let's say, the healthiest of the healthiest, Division I college athletes, the likelihood of myocarditis, even after mildly or asymptomatic COVID, is around 1.5% to 2%. So 2 out of every 100. And we're talking about rates of myocarditis after vaccine that are in the 1 in tens of thousands, hundreds of thousands of individuals. So if I'm asking, am I going to get myocarditis from the vaccine or from the disease? It's far more likely from the disease. This is another reason why we want to protect even our younger children.
And it seems different too, doesn't it? The myocarditis you get from COVID versus the vaccine myocarditis, which they tend to recover very quickly from.
It does. Yeah, that's exactly right. So the average length of stay for a typical myocarditis is about a week. These individuals that have it after vaccination are often in the hospital for maybe a day or two, and they rapidly improve, often without much therapy at all. And in work being done throughout the country, but including at Vanderbilt by several of our pediatric cardiologists, our adult cardiologists, what we're seeing is that the patterns of inflammation are a little bit different. And now there's a large CDC study called the Moving Study, where we're able to call these parents 3, 4, 5 months after the initial diagnosis to ask how they are doing. And I think in meetings to come, we're going to have even more data about this that I think is going to corroborate what we've seen so far, that these children get better very quickly, that there are not long-standing effects, though there can be from COVID-related myocarditis.
And speaking of parents, in your practice, you interact with parents. What are you hearing from them, particularly with VRBPAC's decision here?
Well, by and large, there's great excitement because they've been hoping to be able to have a vaccine for quite some time. And that's often in families with either high likelihood of exposure or, quite frankly, a desire just to go back to the freedom of doing what we want to do, right? We're not only are we missing the halcyon days of not having to do any of these mitigation efforts, boy, the spring feels like an eternity ago when vaccinated people didn't have to wear masks anywhere. We can get back to that very quickly, I think, the more we're protected, right? And this is where boosters and where pediatric vaccines are going to come in. I do think parents are asking the right questions, which is to say, is there anything that we need to do differently for kids? And in fact, there is. We need to give them a lower dose of the vaccine. And that's why we had to do these extra studies and not just treat children like, little adults. So we've done that. We figured out that their immune system is awesome and we can give them a lower dose. That should also reduce the likelihood of these short-term side effects that we see. It certainly reduces fever and arm pain and the achiness that we as adults feel after the vaccine. I think the other thing that they're worried about are long-term side effects of the vaccine. And I think this is where I just reiterate that, when we see side effects from vaccines, they almost always fall into 3 camps. Either right away, an allergic reaction, extraordinarily rare. Lightning strike, 1 in a million kind of thing. The week after vaccine, where we typically see arm soreness, fever, achiness, the things that come with the territory. The third group is in the first 6 weeks, maybe 8 weeks. And that's where we see some of the most rare of rare complications that might be caused by the vaccine, or at least associated with the inflammation that they generate. But I think it's important for parents to realize that if we don't see those types of side effects in the first few weeks after vaccine, we don't have any other example of a vaccine that causes side effects that show up years later. And I think a lot of parents, when they hear that, they breathe a sigh of relief, and that's one more data point that they can use to make a good decision for their family.
And then one of the big questions I get often from parents is about the fertility question they have. And you know, I frequently talk about adults and how, you know, that statement came to be, which was disproven and it doesn't really have any issues. What do you tell them as far as children?
Well, I'm a nerd, so I usually nerd out and talk to them about the DART studies that were done. These stand for Developmental and Reproductive Toxicity Studies. And this is where we take small animals in a humane manner, but we give them just absolutely large amounts of the vaccine or the drug or whatever it might be. And by doing that, we're able to then assess, does it accumulate in any of the organs like the ovaries? And the answer for these vaccines is no. Is there any issue when given to pregnant small animals? The answer is no. And then we look to the clinical trials where pregnant women were asked not to participate in the studies, but inevitably people became pregnant during the study. And we followed those pregnancies out, and we saw that there were no unusual side effects that were seen, and there were no abnormal effects on the children. Now, what we have seen, and I think this bears an important statement, which is just that we have seen reports of adolescent and young adult women who have had abnormal menstrual cycles in association with COVID, as well as after COVID vaccine. And what we're seeing with that is it appears to be the inflammation that we see either in response to infection, we see that with other infections too, or after the inflammation that's generated from a vaccine. Those are short-lived. They don't have any impact on fertility, but those studies are underway right now so that we can give parents even more reassurance about that.
And when you look at parents right now, the surveys they do on them looking at vaccines and whether they're going to get their children vaccinated, it almost breaks down into a third want them vaccinated right now, a third are wait and see, and a third are basically saying, we're not going to do it at this point. That wait and see middle period there, those third parents, what would you tell them?
Well, I think there are some people who go out and buy the most recent iPhone, and there are those who are not early adopters and they wait to get the kinks out. Thankfully, making vaccines is a little different than that. It's a little more rigorous than the new operating system from Apple or whomever. So I would say that if there are those who want to wait, I think there's a couple of approaches there. The first approach is to have an honest conversation with your pediatrician to ask, is it safe to wait? And the answer might be, in some areas based on exposures, sure, you can wait a week or two, you can wait a month or so. But that makes me nervous for a lot of kids, I'll have to be honest, and for a lot of families. The other option to talk to your doctor about is, you know, what we've studied in these vaccine studies is a regimen of either 3 weeks apart for the Pfizer vaccine or 4 weeks apart for the Moderna vaccine. But we also know that extending that interval between the two doses, that actually, in the studies that have been done so far, actually improves the immune response. It actually leads to a more durable response. It comes at a cost, right? And that cost is a longer period of risk of infection. But there may be some children, especially those who have had a documented history of infection, where maybe you start with 1 dose, and maybe that second dose is a discussion with your pediatrician so that they're not coming at that, 1 day and then 3 weeks later clip. I don't want to make that formal recommendation because that's not what has been studied most rigorously yet. But we know from the adult studies of other countries, the experience in Canada and the UK and elsewhere, that extending that interval to more like 12 weeks is really good from an immune system standpoint. So those are the kinds of conversations I would have as a pediatrician, just trying to talk through things. We all want the same thing. We want our kids to be healthy. And it's just a matter of how we can talk through the details to get there.
And that's an important point. Keeping kids healthy is a priority. getting parents that information can certainly move a long ways in that direction of making sure that they stay healthy and parents can make their informed decisions. Now, we're coming into our winter months, and some people are dubbing us the Delta winter because it's going to be the first winter with the Delta variant that we talked about. Are you worried at all about kids here, particularly, they're in school, there's going to be holiday travel, getting together with other people? Any concerns?
Well, I think it's going to be a challenge, not just for COVID, but for the myriad other respiratory viruses that are indistinguishable from COVID until we do testing. So I think pediatric offices are going to be really busy swabbing kids to look to see if they have influenza or RSV or COVID or one of the other viruses that we see in the wintertime. I think none of us can truly predict how those other viruses are going to behave because we didn't think we would see RSV in the summer, and yet our hospitals were filled with it. We haven't yet started to see a lot of flu, but I would just remind parents that anything we can do to prevent the likelihood of our child developing a respiratory illness that then leads to a whole lot of work for us and potentially a whole lot of discomfort and maybe severe disease in the child would be a good thing. So what that means for us is everybody getting their flu shot, not just the kids, but the whole family. And then the second thing is for those who can get a COVID vaccine, get that COVID vaccine. It just takes other viruses off the table, at least for now. There are plenty that we don't have vaccines about or for. We'll get there when we get there. We're trying hard, but for now, let's prevent the things we can prevent.
And the other thing I like to remind parents is number one, flu season, get your flu vaccine, you and your children, but also with the Pfizer vaccine, it takes 5 full weeks to get fully immunized with the vaccines. With Moderna, that's going to hopefully be coming out soon, 6 full weeks. And so if it passes according to the way we think it's going to, so just if you are going to be traveling this winter, think about getting vaccinated early so that way they're protected. But Buddy, I like to leave people with some hope in the pandemic here. So what would your bottom line be to people?
Well, right now we're at a new place, right? We've got pediatric vaccines on the horizon. In many areas, we've endured a Delta wave that pushed our medical facilities to the brink, to the point that we're delaying elective surgeries and not able to provide care for the non-COVID related things that are still out there. I think everyone in healthcare is really exhausted right now. I think everybody in the world is really exhausted right now. We're done. We're done with all of it. But now's the time, I think, to really have hope. What we're all looking for is a wave that comes through that is not associated with hospitalizations and death and the complications that we see from COVID. When we see that wave happen, I think that's going to be a harbinger of some really bright days ahead. We're still following the same goal that we had at the beginning of this, which is to flatten the curve. I don't think any of us are arrogant enough to think that we can eradicate this virus. I do think we have the tools to turn it from a potentially fatal infection to one that is just a member of the other cold viruses that we suffer from. Vaccines are the way we do that.
Buddy, thank you very much. And as always, it's Dr. Buddy Creech, a friend of the show, as we say here, a friend of mine. He's the director of the Vanderbilt Vaccine Research Program. Font of knowledge as always. Thank you very much for your expertise and for helping us get through all this.
Thanks, John. It's a pleasure as always.
All right. Have a good rest of your week.
You too.